Good evening and welcome to all academically oriented pediatricians. It is 1st and 9 p.m. We are with our academic feast of journal journey. Maharashtra IAP with Raigad IAP is carrying this activity for nearly 2.5 years. And it has crossed the boundaries of Maharashtra, and we are very fortunate and blessed to have our VP, Dr. Shantanu Dev sir, for this meeting. For a formal welcome, may I invite Dr. Neha Singh, our EB member and editor of Raigad IAP. Over to Dr. Neha.
Thank you, Chitra ma'am. Good evening, everyone. Myself, Dr. Neha Singh, and on behalf of Maharashtra IIP as well as Raigad IIP, I welcome all the respected dignitaries, colleagues, seniors for today's journal journey. I welcome Maha-IIP President Dr. Ram Gopal Chezara, Secretary General Dr. Amol Pawar, as well as other respected executive board members of Central IIP as well as Maha-IIP. I also welcome Raigad IIP President Dr. Vikas More sir, Secretary Dr. Ajay Kohli, respected Dr. Neeman Mohanty sir, past President Maha-IIP Dr. Hemant Gangulia sir, Jay Bhandarkar sir, Dr. Chitra Kulkarni ma'am, and all the members from Raigad IIP as well as other branches. Today we are very fortunate to have with us Vice President National IIP East Zone, Dr. Shantanu Dev sir, as our guest of honor. Sir is also Senior Consultant and HOD Pediatrics at Meghalaya. Sir is has been EB member of Non-Communicable Diseases Preventive Academy in 2022-23. Sir, we welcome you. Please give your blessings.
Thank you, Dr. Neha. My respectful regards to all of you from Maharashtra IIP and Raigad IIP. But my special regards to Dr. Neeman Mohanty sir. So when I was doing my post-graduation, at that time he was posted in Guwahati. So during our meetings as students in IAP Assam, IAP Guwahati, NNF Assam, NNF Guwahati, we used to meet him very frequently at that time. And I was, of course, just a postgraduate student, but we used to be interacting with him in our meetings. So nice to see you, sir. In the last meeting when I had joined, you were not there. You were busy with some other engagement. And I wish all the presenters of both the topics and the experts to have a very fruitful academic evening. I may not be able to stay for long because of my poor network, because I have been traveling from Raipur to Shillong today. So I wish you all the best, and I hope you will have a very fruitful evening. Thank you, sirs.
Thank you, Shantanu sir, for joining us and your blessings. Attendees, please note today's session has been granted 1 MMC point. So I request everyone to please type your name, Central IP number, MMC number, and city in the chat box. Dr. Vijay Mandale, Senior Pediatrician from Nasik, is our MMC observer for today. Sir may be joining us soon, and we will acknowledge and welcome him as soon as he joins. So friends, today's session we have two experts with us. Pallavi ma'am, the slides. First expert is Dr. Himesh Varman sir. Sir is Professor and Head Department of Pediatrics at NEIGR IHMS Shillong. Sir has been practicing for last 16 years as pediatric nephrologist. Sir has indexed 38 papers in national and international journals, 4 book chapters, and completed 7 multi-centric extramural projects. While our second expert is from Nagpur, Dr. Pramod Ambadkar sir. Sir is consultant pediatric cardiologist at Ruby Child Health Clinic, Nagpur. Sir is also associate consultant at Max Sanket Hospital, New Delhi. While our presenters for today is Dr. Anamika Mall, consultant neonatologist and pediatrician at Shillong, Meghalaya. She is also IIP Meghalaya editor in 2023-24, IIP Meghalaya secretary in 2018-19. She has a special interest in newborn care in resource limited settings. She will be presenting on evidence-based clinical practice guideline for management of urinary tract infection and primary VUR. While our second presenter is Dr. Sadhna Swami. She has done her fellowship neonatology from KEM Pune, currently working as neonatologist at New Health City Hospital, Nagpur. And she will be presenting the article Transcatheter and Surgical Ductus Arteriosus Closure in Very Low Birth Weight Infants. So now I first request Dr. Anamika to please share your slides and you can start your presentation. Over to you.
Thank you, Dr. Santanu, instantly recognizing me. And I was also posted in Shillong for some days, 3 to 2 years also after Guwahati.
Okay, sir. Now, how can I forget you, sir? Because those were my formative years also, and I was just becoming a pediatrician at that time.
Yes, Dr. Anamika.
Start?
Yeah, please start.
Everyone, good evening, everyone from Maharashtra and Meghalaya, and thank you for Maharashtra IIP and Raigad IIP for considering a small state of Meghalaya and few pediatricians we are for being part of your journal journey. We feel very lucky and nice that somebody has been thinking about us. With the guidance of Dr. Shantanu, our Vice President East Zone, and Dr. Himesh, our President of IIP Meghalaya, we are trying to make big noise from a small state and trying to bring some difference in pediatric healthcare in our state. So without any further delay, I'll be starting my presentation on evidence-based clinical practice guidelines for management of urinary tract infections and primary VUR. It's a multi-centric, multi-author guidelines which were recently published in October 2023. The impact factor of the journal in which it was published, Pediatric Nephrology, is 3. So why do we need new guidelines? Guidelines, the first guidelines which were ever published by Indian Society of Pediatric Nephrology was just a consensus statement, and it was published in 2001. Guidelines were again revised in 2011 after a gap of 10 years and was a quasi-evidence-based update. So till now, in last 13 years, many new studies have been conducted. Therefore, there was need for new evidence-based clinical practice recommendations for optimal management of UTI and VUR. So about the guidelines, 9 new systematic reviews were performed and 7 existing ones were used for these guidelines formulation. The authors have made 17 recommendations, which are based on systematic reviews and meta-analysis. Out of that, 14 recommendations are for UTI and 3 for primary VUR. 18 clinical practice points are formulated, which are based on the opinions of the author or from limited literature. 12 are for UTI and 6 for primary VUR. So just starting with introduction, the definition of UTI itself, everyone knows, is growth of significant number of organisms of a single species in the urine sample in the presence of symptoms. 2% of boys and 7% of girls experience at least one episode of UTI in first 6 years of life. Incidence amongst neonate is 1% amongst term neonates, where males have more chances of UTI in compared to females because of anatomical problems. And in preterms, the incidence is 3%. The risk of developing UTI is equal in both male and female during infancy. And as the children grow, the risk of developing symptomatic UTI is just 1 to 2% in boys and 3 to 8% in girls. We all know that the most common organism in UTI is E. coli, which has prevalence of 80%. Other organisms are Klebsiella, Proteus, Staph, Group B, Streptococcus, and Salmonella. But in children who are hospitalized for longer duration, immunocompromised infants, or those who are on prolonged antimicrobial therapy, the chances of Candida is very high. So the clinical symptoms all of us know, so I'll be just rushing through it. In babies who are less than 2 months, main symptoms seen is fever, vomiting, irritability, poor feeding. And in babies who are 2 to 24 months, they can complain of abdominal pain, increased frequency, or hematuria or foul-smelling urine. And in children more than 2 years, there is examination findings of suprapubic pain, tenderness, or cloudy urine, along with other symptoms. Clinical findings can be very specific during examination for certain anomalies. If there is a palpable kidney or a palpable bladder with suprapubic tenderness, obstructive uropathy or urogenic bladder should be suspected. If on examination we get costovertebral angle tenderness, pyelonephritis can be the diagnosis. And in constipation, there'll be a palpable fecalith. And in certain cases of occult meningomyelocele, there'll be a sacral dimple, tuft of hair, lipoma, or abnormal evaluation of lower limbs or perianal sensations. So now in these guidelines, they have put a lot of emphasis on sample collection. So these are the different ways in sample collection can be done using adhesive bags, urine bag, clean catch urine, or voiding stimulation. And these are non-invasive methods of sample collection. For invasive methods, they have advised catheterization or suprapubic aspirate. But sample collection can be a challenge. What the experts have recommended that urine bag, adhesive bags or nappy pads should not be used because there is a very high chance of contamination while collecting urine through urine bag or nappy pads, up to 30 to 80%. So you can collect urine sample through these if possible, but you cannot send this particular sample for urine culture. Contamination rate of clean catch is just 5% and is acceptable when directly compared with contamination rate of catheterization, which is 8% in babies who are less than 3 months. Contamination rates in clean catch vary based on gender and age group also. Contamination rate can be high if it is collected in the first stream, about 5 to 7% in comparison to late stream. So they have recommended to collect urine late stream during catheterization. Clean catch is the most preferred method in toilet-trained children, but it can be challenging in collecting sample in non-toilet-trained children. But it should be attempted whenever possible. And clean catch method has been found to be most cost-effective and non-invasive. Whereas for catheter and suprapubic aspirate, you need expertise, you need training, and these are invasive, painful procedures. So what is a quick wee method? A quick wee method is that you stimulate the suprapubic area with cold and wet compresses in circular movement, and then the baby will pass urine, and then we do a clean catch directly in a sterile container. But the prerequisites for quick wee method is that cold and wet compresses should be used, which can be 10 ml normal saline, kept in refrigerator at 2.8 degrees Celsius, and used within 2 minutes after removing from the fridge. We have to try to collect midstream urine in a sterile container. So sample collection in toilet-trained babies as much as possible should be clean catch. In non-toilet-trained, if unsuccessful, we should catheterize or do suprapubic aspiration. In sick infants, catheterization and suprapubic aspiration is preferred. This is the first clinical practice point. The rationale is that the contamination rate is less in comparison to nappy pads or adhesives. And in catheterization, we have high success rate, but chances of microscopic hematuria is very high. And it's painful procedure. So diagnosis, how do we reach? The first line of screening test, which can be done in office or in ward bedside, should be urine dipstick, in which we look for leukocyte esterase and nitrite combination. When feasible, urine microscopy for bacteriuria or leukocyturia in a freshly voided sample should be done, which can be an alternative to the dipstick for screening of UTI. These two are recommendation 1 and recommendation 2. The rationale is that urine analysis, when done on a freshly voided sample, requires that the sample should be analyzed within 1 to 2 hours at room temperature, or should be kept up 4 hours in refrigeration, and sometimes we do not get the report right away. Suprapubic aspiration and catheterization is invasive. You need trained personnel for processing the sample. And for urine dipstick, we just need to assess leukocyte esterase and nitrite positivity, which can be seen immediately as the sample is collected. The sensitivity of both the tests is 84% and specificity is 88%. And when both are positive together, sensitivity and specificity goes up to 98%. So we don't have to delay for starting treatment. We can start the treatment right away. What is significant for diagnosis? Significant growth of a single bacterial species on urine culture in the presence of symptoms is suggested of UTI. The growth of single uropathogenic bacteria more than 10 raised per 3 or 10 raised per 4 or in the range of more than 10 raised per 4 in urine obtained by suprapubic aspiration or catheterization and clean catch are highly suggestive of UTI. The rationale is The use of strict conventional cutoff of more than 10 raised by 5 might miss the diagnosis of UTI. So in the current guidelines, they have recommended that we can go from the range which I have mentioned before. This is clinical practice point 2. Now, what about asymptomatic bacteria? If we have sent a sample and the sample is positive for culture for an organism, what do we do about it? So what they have defined as the presence of positive urine culture, more than 10 raised by 4:5 of a single uropathogen in clean catched urine, or more than 10 raised by 4 in catheterized or any growth more than 10 raised by 3 in suprapubic specimen in the absence of symptoms is asymptomatic bacteria. Prevalence of asymptomatic bacteria has been reported as 0.37% in boys and 0.47% in girls up to 19 years. The prevalence is higher in boys below 2 years of age compared to older boys, while it is higher in older girls in comparison to the younger ones. So the diagnostic algorithm which they have suggested is fever without focus, more than 48 hours in less than 2 years old, or presence of risk factors. The risk factors are bladder bowel dysfunction, primary VUR, or previous history of UTI. You should perform a urine culture and do dipstick simultaneously if possible. If the dipstick is leukocyte esterase positive or nitrite positive, start empirical antibiotics. Then you wait for the urine culture. If it's positive, you continue the antibiotics. And if the dipstick has come negative, but the age is less than 6 months or the mentioned 3 risk factors are there, you start empirical antibiotic, wait for the urine culture. If positive, continue. If urine culture is sterile, then you stop. But if the dipstick is negative, child is more than 6 months and no risk factors, wait for the culture. If culture turns out to be positive, then only start antibiotics. No role of empirical antibiotics in such cases. Then what about treatment? Antibiotic therapy should be initiated as early as possible, preferably within 48 to 72 hours of onset of fever. This is a clinical practice point 3. And clinical treatment failure, if it occurs and the child does not have resolution of symptoms, then change in initial antibiotic therapy can be done regardless of the antibiotic sensitivity pattern. This is clinical practice point 4. The rationale is the earlier we start antibiotics in suspected cases of UTI, there is reduced morbidity and kidney damage, significantly higher risk of kidney scarring with delay in initiation of antibiotic therapy after the onset of fever has been mentioned in many studies. Third generation cephalosporins or amoxiclav is the empirical antibiotic therapy in suspected febrile UTI, has a strong recommendation. First generation cephalosporins like cefalexin or cefadroxil or amoxiclav can be empirical antibiotic therapy in adolescents with cystitis. Oral antibiotic therapy for treatment of acute febrile UTI has to be started except for these 3 cases: when the child is less than 2 months, or severely ill or sick patient, or patients who are not able to ingest oral antibiotics, then we can go for IV antibiotics. The recommendation by the guideline is that the antibiotic should be given at least for 3 to 7 days in cases of cystitis. 7 to 10 days of antibiotic therapy is suggested in children with acute symptomatic UTI. It's a clinical practice point. And antibiotics are not suggested for treatment of asymptomatic bacteriuria. Routine urine cultures should not be performed in asymptomatic patients. Treatment algorithm is as follows. We have diagnosed with UTI. If there is a cystitis, consider it very commonly seen in adolescents, start oral antibiotics and give for 3 to 7 days. If it's a febrile UTI or pyelonephritis is suspected on examination, child is less than 2 months, there is sepsis, renal angle tenderness, or poor oral intake, IV antibiotics to be initiated and given for 3 to 4 days. Look at the clinical response of the child. If there is good response, switch from IV to oral antibiotics and give for 7 to 10 days. If the child is older than 2 months, has no features of pyelonephritis on examination, start oral antibiotics, look at the clinical response, and decide whether you want to continue or you want to wait for urine culture or ultrasound. So these are the antibiotics which are recommended: amoxiclav, cefixime, cefuroxime, in IV ceftriaxone and cefotaxime, aminoglycosides like amikacin, and in prophylaxis they have recommended cotrimoxazole, nitrofurantoin, cefalexin as oral prophylaxis antibiotics. Now, what about imaging? So there are many changes in imaging recommendations. What the guidelines suggest, if it's a first episode of UTI, every child should undergo ultrasonography. And at the same time, we have to assess for bladder bowel dysfunction. If the ultrasonography is abnormal, MCU should be done, and late phase DMSA scintigraphy should be done at 4 to 6 months. And all patients who are diagnosed in MCU with VUR, they should undergo DMSA. If the ultrasound is normal, we do not need to do any further investigations like MCU or DMSA. We just have to keep the child in follow-up. For non-E. coli UTI in less than 2 years of age or recurrent UTI, ultrasound should be done, followed by MCU. And if VUR is detected high grade or recurrent UTI, DMSA should be suggested after 4 to 6 months. So approach, the recommendation made is ultrasound scan of UTI should be performed after first episode of UTI in all children of all age group. MCU is performed in children with one of the following: UTI caused by non-E. coli in children less than 2, abnormal ultrasound, or history of recurrent UTI. Guideline also suggests to perform late phase DMSA scan to assess kidney scarring with recurrent UTI or high grade VUR. Recommendation that acute DMSA should not be performed in any febrile UTI. How do you go about preventing UTI? Guidelines suggest that recurrence of UTI in children was seen in 10 to 30% following a first episode of febrile UTI. What are the risk factors for recurrence? Either it's primary VUR or bladder bowel dysfunction. Since 10 to 15% of patients with acute pyelonephritis may develop kidney scarring, it is important to prevent febrile UTI in future. Guideline also suggests against using antibiotic prophylaxis for prevention of UTI in patients with normal urinary tract and absence of bladder bowel dysfunction. Antibiotic prophylaxis should be given only in proven cases of high grade 3 to 5 VUR. Antibiotic prophylaxis may be considered in recurrent febrile UTI and bladder bowel dysfunction, irrespective of presence or absence of primary VUR. So these are recommendation and clinical practice points. The rationale is antibiotic prophylaxis, when given without any evidence, little or no efficacy is there to prevent recurrence. Significant risk of antimicrobial resistance is there, and it reduces overall cost by decreasing UTI caused by resistant uropathogens. Antibiotic prophylaxis for preventing symptomatic UTI in children with antenatally detected hydronephrosis can be given while we are waiting for their complete evaluation. Children more than 3 months, such children, we can start them on cotrimoxazole or nitrofurantoin. We should discontinue antibiotic prophylaxis once the child who has any kind of anatomical abnormality more than 2 years old, if the child is toilet trained, and there is absence of bladder bowel dysfunction and no febrile UTI in the previous 1 year. Circumcision can be considered for at-risk children like high-grade VUR, grade 3 to 5, or in recurrent UTI. Cranberry products, which are widely used, can be used in recurrent UTI and normal urinary tract infection. Now, briefly about bladder bowel dysfunction. It is commonly observed in children with UTI and encompasses a spectrum of lower urinary tract symptoms accompanied by constipation and or encopresis. In history, there's a history of incontinence, voiding postponement, holding maneuvers, increased frequency and urgency. History of constipations, we have to ask for stool firmness, frequency, painful defecation, or encopresis. On examination, there'll be a palpable fecalith in the left iliac fossa, and clinical evaluation is supplemented with at least 2-day voiding diary. Less than 4 voids in a day is abnormal, or more than 7 is abnormal, and detail of bowel movements over 2 weeks. All children with bladder bowel dysfunction should be managed with urotherapy for preventing recurrence of UTI. All toilet-trained children with UTI should be evaluated with for bladder bowel dysfunction. So what about VUR? So what is vesico-ureteric reflux? Retrograde passage of urine into the upper urinary tract during detrusor contraction is defined as VUR. Primary VUR is in absence of obstructive uropathy and neurogenic bladder dysfunction. They are low grade and high grade. Grade 1 and 2 on MCU is low grade, and grade 3 to 5 is high grade. Surgical reimplantation has been recommended in high grade VUR only with recurrent breakthrough febrile UTI or antibiotic prophylaxis. The rationale is that surgery plus antibiotic prophylaxis in comparison to patients who just were on antibiotic prophylaxis, little or no difference to the number of children developing new kidney parenchymal abnormalities seen, either at 2 years or at 4 to 5 years. The risk of progression of an existing abnormality was similar in both the cases at 4 to 5 years. Surgical intervention in patients may be given, those patients may be given an option of endoscopic injection of bulking agent as initial therapy, but it has lower success rate in comparison to implantation. The rationale behind suggesting endoscopic injection of bulking agent is that after the reimplantation, there's longer hospital stay, they need post-operative analgesia, risk of post-operative complications are very high. Follow-up of VUR, high-grade VUR and reflux nephropathy, periodic follow-up to detect long-term complications is important. We have to assess their growth, blood pressure, proteinuria, and kidney function at each visit. Ultrasound for persistent high-grade VUR should be done. And recurrence of UTI in VUR, if it occurs again and again, we should repeat DMSA during follow-up. Repeat cystography is not necessary in VUR, but can be repeated after 4 to 8 years at the discretion of the treating physician in high-grade VUR. And if there's a siblings of a diagnosed case of VUR and siblings are less than 3 years, they should be screened with an ultrasound. So the treatment algorithm for primary VUR, if it's a low grade 1 to 2 and there is no evidence of UTI, no prophylaxis. If there is episode of UTI and bladder bowel dysfunction is not diagnosed, no need of giving any antibiotic prophylaxis, just keep them in follow-up. But along with VUR, there is bladder bowel dysfunction, antibiotic prophylaxis should be initiated. In all cases of high-grade VUR, antibiotic prophylaxis has to be given irrespective of presence of bladder bowel dysfunction. If there is recurrent UTI in such cases on prophylaxis and no bladder bowel dysfunction, please recommend ureteric reimplantation and endoscopic injection. Recurrent UTI has been defined by the guidelines as 2 episodes of febrile UTI. So the take-home message from these important guidelines is that urine dipstick can be used as first-line screening test for UTI. Initiation of prompt antibiotic therapy, 3 to 7 days of oral antibiotic for cystitis, and 7 to 10 days of antibiotic for acute symptomatic UTI. Briefer duration of antibiotic prophylaxis has been recommended to reduce antimicrobial resistance. Invasive procedures, investigations like MCU and DMSA in only recurrent UTI or abnormal ultrasound has been recommended. Surgical reimplantation may not be the first line, even in high-grade VUR. Recommend antibiotic prophylaxis. And stress is more on to screen bladder bowel dysfunction in such children, and imaging evaluation is less aggressive for VUR and kidney scarring in comparison to the previous guidelines. The shortcoming of this guideline, they do not address fungal UTI or UTI in complex congenital anomalies like posterior urethral valve or neurogenic bladder. Thank you.
Thank you very much, Dr. Anamika. It was an excellent presentation and elaborative description with slides and everything. May I request expert Dr. Himesh to give his comments on this article.
Good evening, everyone. First, let me start by expressing my gratitude towards leadership of Maha IIP and Raigarh IIP for giving us the presentation. I pay my regards to Dr. Shantanu, East Zone BP, Chitra ma'am, Mohanty sir, Vijay Mandale sir, Neha Singh ma'am. So, and let me also congratulate Anamika for a beautiful presentation. It's a very long document, and she has actually covered that in very well in such a short time. For all the postgraduate students and the academic pediatricians who are present today, I will strongly encourage them to regarding the rationale and the evidence is there that could not be covered in this just 20-25 minutes. But for practitioners who are not into hardcore academic pediatrics, there is another article published in Indian Pediatrics by Jitendra Meena, Pankaj Hari sir and his team, which summarizes this article. So that is a shorter read, and that gives the gist of the article, and you should be able to carry home the key practice points from it. Overall, saying as Anamika has also pointed out, this is a very robust article, and that has survived the rigorous review at international level also. Pediatric Nephrology Journal, you may know, is the highest dedicated pediatric nephrology. It's a official art journal of IPNA, the International Pediatric Nephrology Association, and this article is so robust that it has survived the international scrutiny. And the basic change from the previous guideline, it is less aggressive and invasive, starting from the point of taking samples, where earlier recommendation in non-toilet trained infants were to take either suprapubic or this one. So suprapubic or catheterized sample, it has come towards more like clean catch sample, even in non-toilet trained. In fact, they have recommended the quick V method. The imaging has been less aggressive. Then the focus is on use of dipstick in office practice. So that is very much doable. This doesn't cost much. And if we have some help at office who can do this test, we can decrease the number of antibiotics that we prescribe waiting for the culture in suspected urinary tract diseases. So I would encourage most office practitioners to adopt this recommendation of using dipstick. And then again, in VUR also, that guidelines has been less aggressive. Earlier, in higher grades, surgery was recommended. Now, antibiotic prophylaxis has been very clearly recommended as the first line. And even where surgery is considered, the endoscopic bulking agents, which was not mentioned in the earlier one, has been included here. So I will not take much time because we have another year also coming. In that, in nutshell, I again congratulate Anamika for doing a very good job. Over to you, Chitrapa.
Thank you. Thank you so much for the expert comments. And please do share the article which you had just mentioned in the chat box so that everybody can click a photograph. Now we move on to second article, which is equally important. And we are having another enthusiastic presenter, Dr. Sadhna Swami. Dr. Sadhna?
Yes, ma'am.
Please share your PPT and start.
A very good evening and warm welcome.
Can we make it full screen, doctor?
Yes, yes. Is it visible, ma'am?
Yes.
So a very warm welcome to all my colleagues, and I am very much thankful and grateful and want to welcome all my seniors for this opportunity. So my topic is discussing patent ductus arteriosus closure in very low birth weight infants, which this study has been done from 2018 to 2022. So two invasive PDA closure procedures have been described: transcatheter device closure and surgical closure. So yes, PDA treatment has always remained a topic of uncertainty with a very wide variable of treatment. But of course, significant PDA that needs to be treated, and significant is of if it is hemodynamically significant, requiring high oxygen requirement, prolonged cardiorespiratory support, signs of congestive cardiac failure, then this PDA must be treated. So the study is transcatheter surgical device arteriosus closure in very low birth weight infants. This study has been done in University of Vermont Children's Hospital, and it has been published in volume 154. So The objective of this study is to determine the survival rate and short-term outcomes among very low birth weight infants undergoing transcatheter device closure and surgical closure of PDA. The eligible infants here are from 22 to 29 weeks of gestation with a low birth weight of 400 grams to 1500 grams. In this study, the Vermont Oxford network has been used. So this network is actually a voluntary collaborative effort of healthcare professionals and hospitals included in this network. They submit their standardized and structured data aiming to provide a good and qualitative NICU outcome care. So the background is this is a retrospective observational study. United States has approved the use of transcatheter closure for newborn more than 700 grams. So this is in short, this figure shows that total 2,16,267 babies were selected, but among them excluded babies were the babies died in delivery room, babies having congenital heart diseases, or who did not receive any pediatric treatment, or if there is any missing information. So remaining, the study was on 41,976 babies. Out of them, the babies received and responded well to pharmacological treatment they have excluded. Now the only invasive procedure done on babies 1,548. Among them, transcatheter device closure was done on 806 and surgical 727. And few babies, like 15 babies, they received both. So the methods used are actually the pediatric treatment data analyzed over year, and it has been averaged the study duration over the study duration. And here they had also tried to use subgroup analysis, and they had tried to compare the adjusted risk ratios in terms of survival of the infant, length of stay in NICU, prematurity complications like bronchopulmonary dysplasia, late onset sepsis, retinopathy of prematurity, NEC, IVH, as well as discharge support if the baby is requiring gastrostomy, tracheostomy, or oxygen support while going home. So the infant characteristics were analyzed, and they have been according to standard summary statistics. They have been described according to standard summary statistics based on general demographic information like birth data and selected complications of prematurity at the time of discharge, small for gestation babies, or babies requiring respiratory support or respiratory distress syndrome, and overall a generalized estimating equation regression models were used to calculate adjusted risk ratios with 95% confidence interval to compare. So this figure is showing outcomes among these babies with invasive treatment in terms of complications as well as support at discharge and survival and length of stay. So they have tried to put the data in a tabular form and had tried to compare. Sorry. So this is the figure showing invasive treatment according to the birth weight as well as according to the gestation age. The blue one is showing surgical treatment and the red one is showing transcatheter treatment. In first figure, as we can see, the mostly surgical closure treatment has been used in below 700 grammars and below 26 weekers. As well as in this figure, we can see that the transcatheter device closure has been used much, has been increased in recent years. Like in 2018, it was around 27%, and 2022, it has around 71%. So the results are total 6,410 babies they received invasive treatment. So device closure, as we had seen in the previous slide, device closure had increased from 29.8% in 2018 to 71.7% in 2022. And the transcatheter device closure had a higher survival with an adjusted relative risk of 1 and almost similar in neonatal complications and length of stay. But in subgroup analysis survival and discharge support, LOS and complications were lower in transcatheter closure. In this table, we can see this is the adjusted relative outcome comparison between both the groups. So in terms of, in the first table, in terms of length of stay and survival, there is not much more difference, but support at discharge home and survival, it is more favorable towards transcatheter. In the second table, this is the subgroup analysis for infants more than 700 grammar done in 2020 to 2022. So in this, we can see that survival and support at discharge were similar in both the groups. Whereas in point of neonatal complications and length of stay, transcatheter closure group is much more favorable. So these studies, they used data from Neonatal Research Network and Pediatrics Clinical Data Warehouse between 2020-21. The median birth weight as well as the gestation in surgical group was lower than transcatheter group. And the limitations of this study was, it was observational. Hence, they were not able to account for the possible selection bias. And also, they cannot comment on the closure timing, intervention sequence, even cannot comment on the adverse events following the procedures, like immediate post-procedure complications, if there is any inotropic support or impaired renal function, hemodynamic instability, or any embolization. So the conclusion is transcatheter PDA closure in very low birth weight babies has been increased after 2018, and selected short-term outcomes for infants receiving transcatheter closure may be more favorable as compared to surgical closure. Also, there has been limitations of transcatheter device closure. It is cost burden to patients, families, and to the healthcare medical system. It is almost, the expense is almost twice of the surgical closure, and it needs a separate catheterization lab, and the device itself is also expensive. So by ending my presentation, I would share my one case which I myself had witnessed. So this is the photo, this is the picture of the baby which was 23 weeker born and underwent transcatheter device closure at KM Hospital, Pune. And now the baby is doing well at 18 months of age. This is the photo. So without any complications, this baby is doing well.
Excellent.
So I would like to thank you.
Excellent. Very nice presentation. And may I request expert Dr. Pramod Ambadkar sir to give his comments.
Good evening, ma'am.
Good evening.
Hello.
Good evening. Sir.
Good evening.
Thank you, ma'am, and thank you, Maha IAP, for giving me opportunity as an expert. This is a large study. Duration is around over a period of 4 years, and is the largest study, the retrospective observational study. In this study, they compare the short-term outcome and the medium-term outcome of the transcatheter device closure and the surgical closure. And over a period of from 2018 to 2022, the number of cases of transcatheter closure is increased. It is due to the expertise in the procedures and the development in the devices, hardwares. there is a one device who is a US FDA approved, that is a Piccolo device. There is an Amplizer device, and include the recommended age for that device closure in the premature baby is 700 gram. Baby should be at least 700 gram and at least 3 days old. And in that recommendation, the characteristic of PDA is very important. The characteristic of PDA is not described in this study, and also timing of the intervention is also not described, whether it is after 3 days or after 15 days. But we usually recommended the closure of PDA by device or any surgical means if there is hemodynamically significant PDA. That is defined by the in the premature baby, that is defined by if the PDA size is more than 1.5, in the premature extremely low birth weight baby more than 1.5 millimeter. If there is a significant pulmonary overflow, that is the requirement of oxygen, ventilatory support, and the or signs of systemic hypoperfusion like GIT intolerance, renal hypoperfusion, or the signs of intraventricular hemorrhage. In that cases, we recommended the closure by device or surgical. Nowadays, if the baby is more than 700 gram or 750, then we assess the anatomy of the PDA because in not every PDA is deviceable. If there is small conical PDA, then we use that device and close, and that size should be, the length of the PDA should be more than 3 millimeters. We use the size of PDA, diameter of PDA, and length of the PDA. If the length of the PDA is more, it should be at least 3 millimeter, and the size of diameter of the PDA should be less than 4 millimeter. In that cases, we use the device closure. If we use device, then definitely hospital stay will be decreased as compared to the surgical procedure, and the complications rate will be the less in the device closure than the surgical closure. But in these cases, the limitation of this study is that they didn't mention what happened after procedure. Whether there is immediately any complication like the device embolism, how many patients fail device, or how many patient needs the surgical. That in Sadhana mentioned the both intervention, the device and the surgery. That means that patient failed device might be get embolized. In that patient, we need to retrieve transcatheterally or surgically. On the surgical ligation, we recommend it. And the life-threatening events can happen during that procedure. And the second primary effective endpoint जो रहता है, that is in the first 6 months, whether it is effective. If there is a total complete occlusion present till the 6 months, that is a primary endpoint of that procedure. And secondly, we follow the patient for the impending coagulation. If we close the device by if we close the PDA by device, there is chance of iatrogenic coagulation or descending. And another complication is the LPS stenosis. That is also not mentioned in this study. How many patients is followed for the coagulation or the LPS stenosis. But definitely, this is last study, and this explained that there is a trend of increasing the transcatheter closure of the PDA.
Yes, sir. I think, have we lost the connectivity with our expert? So now it's a time for question answers. Dr. Neha, any question answers? You can see.
Hello.
Yeah, yes, sir.
Hello.
Continue. Yes, sir.
So, due to increase in the expertise of the operator and the development in the hardwares, there is a increase in the trend of transcatheter closure of the PDA. But not every PDA is deviceable. That is a very important.
Yes, sir. Thank you, Dr. Pramod Ambedkar, sir, for your expert comments. And also, you have pointed out the shortcomings of this research article. Thanks for that. We move on to question answer session now. Any questions you could see, Pallavi ma'am?
Ma'am, there were a few questions, but
Yes, please. Yeah.
Dr. Hirman sir has already answered those in the chat box.
Chat box. Okay.
Yes.
Any questions about this second article of PDA?
Ma'am, there are no questions. No questions, ma'am.
Okay, thank you so much. And may I request our past Maha IAP President, Dr. Hemant Gangolia, sir, to give his comments and the plan for next month journal journey episodes. The articles have already been selected and told by our mentor, Dr. Nimen Mohanty sir, on the personal level, as well as our journal journey group, and the presenters and experts are attending this episode. I am thankful for that. Over to Dr. Gangolia sir.
Thank you, Dr. Chitra madam, and good evening to each one and all who are present on this dais, as well as Dr. Nimen Mohanty sir, Dr. Shantanu Dev sir, as well as presenters and the experts. At the outset, I would say hearty congratulations to IIP Raigad and the team led by Dr. Chitra madam and Dr. Neha Singh. We have moved from, already she said, 2.5 years, we moved from small district branch to the other intra-state districts of Maharashtra, then went on to Gujarat, Andhra Pradesh, Telangana, and now we had one more state, Shillong, there. And excellent presentation by Dr. Anamika. And Dr. Anamika, the small branches make big noise. As IIP Raigad is also a very small branch, and now we had become across the country. And so I am very sure that Shillong branch will also make very, very big noise at the country level. And it was excellent presentation by you, madam. As well, excellent time management. And but we have finished in time. But few questions I will just leave to them. And regarding the future program, I think so. We are in time. We are getting articles from respected Dr. Nimen Mohanty sir, as well. I think so. We are moving ahead in a very good way, and already I think so. There's already what suggestions were suggested in last 2 or 3 episodes. It has been carried forward. I think so. It has been done wonderfully. I'm sure that we will have these presenters and experts available. As suggested also, our Maha-IP scientific convener, Dr. Satish Shane sir is also there. So he will be looking out for these experts and the presenters. And hearty congratulations to both IIP Raigad office bearers as well as Maha-IP office bearers to continue this trend of the journal journey. With the presentations, I will just have a few questions. Probably, what is the role of use of, because though it may look rubbish, but then what it is used in pediatric practice as well as the rural practice. What is the role of alkalizer? What is the role of some Ayurvedic medicines? Is there any study which shows that some Ayurvedic medicine, if used, causes something for the UTI? And then this question is for Dr. Anamika, as well as Dr. Expert. Which company do you recommend? Which company do you recommend, of whose districts we should use? Because there may be some false positive results also. So which company do we recommend as a general pediatrician we should use in rural practice too? Because and it is the same thing across the country at periphery. The urine examination is very difficult. We collect urine in the morning and this comes sometimes report in the evening by the labs. And there is a transport and all this mechanism out there. I will not go into detail, but still the company which you recommend for the districts. This is regarding the first presenter. And the second presenter, Dr. Sadhana, you have done excellent. And I think so it was a great work by you. But that last slide which you showed, a small baby, I think so that images were of Vitthal Mauli. And I think so what was the age of that child? when it got well and that photo was taken. I'm just curious about the age and how is that baby doing. And
The
excellent time
age
management.
is
Once again, hearty congratulations to both IIT Raigad office bearers and Mahati office bearers. Yes, Dr. Anamika first, and then Dr. Sadhana will answer my queries or for all of us. Thank you.
thank you.
Thank you, sir. Thank you for your question. But honestly speaking, the company, I didn't check with my lab in the hospital. But definitely I will check. But the issue with what I have seen with the dipsticks long time ago, we had a situation like this in which we had to give to the patient. The issue is that the expiry date should be checked because many times dipsticks are not used and they are kept expired. So it's very important we check the expiry date, then only we'll know their efficacy. Another thing is how they are stored in what kind of environment. In Meghalaya, our normal temperature during this season is between 20 to 24. But in mainland India, the temperatures vary a lot. It's very hot. So it's very important that the storage of the dipstick should be done in that dark black color box in which it is available, given by the supplier. And also all of them have that silica dust. Those pellets are there. So that's how it should be stored. I feel that if the storage is done the right way and the dipsticks are not expired, then I don't think there'll be any issue in detecting the efficacy of the test itself.
Yeah.
Regarding use of yes, ma'am. Yes, sir. Go ahead.
Yes, sir. Regarding first, just add on the point on that dipsticks. So, sir, most we have used dipsticks with of this brand called Heuristics. That's a very brand by Bayer Medicals. So that's one that can be used. We have also used by a lesser known brand called Mission by brand. So that also gave us good results. But more or less, if any decent brand is used, results would be okay, I think. But the more important thing is we should start using it. That's important. And in office practice, that also depends that if you're working in an office, you may need some help to perform this test. Somebody will need to be able to do it. So if you have a nurse or a paramedic who is helping you out with this, many of us may be helping hand in an office. So that's a good to start. And those care, as Anamika has said, should be taken. Regarding alkalizers, there is no evidence that it helps in any way, except for there is some low quality evidence on protease infection if it is there. So that might be helpful. But apart from that, there is not much of that. Regarding Ayurvedic products, I'm not aware of many of the results, but none of the documents talk about it because our primary goal is prevention of scarring in the kidney. So that's the goal. The symptom is another thing, but the most of the researcher looked at the primary outcome and repeated infection. So of the your phytochemical products, if I group into the Ayurvedic, only the cranberry products has been shown to be effective. So I do not remember the dose, but there are specific extracts that dose is also defined for that where it can be used. But apart from that, I am not aware of any significant research in this purpose where we can make a recommendation.
Sir, can we recommended water intake, the specified water intake to prevent especially the stasis and clearance then?
Sir, ma'am, actually, it all boils down to, if we look at urinary tract infection, it all boils down to having a functional or structural abnormality of the urinary tract. It boils down to just that simple. That will cover 98% of, or maybe 99% of all the cases. And if one opportunistic some UTI happens, this will not go to recurrent UTI. So water intake and all these are part of good habit, but they may not directly translate into helping with prevention of urinary tract infection. One point I want again try to emphasize here at this point is we as clinicians do not screen for bladder bowel dysfunction. So that is very, very important. So we must, and in bladder bowel dysfunction, constipation is one thing that leads to this one. So the relationship between constipation and UTI is a thing. And this has also been shown that in children with VUR, where they have some bladder bowel dysfunction, there is delay in resolution. So in clinical practice, we underutilize the need for screening for bladder bowel dysfunction that we should all do by And we should utilize bladder bowel diaries, as Anamika has said. So we need to ask, if we are suspecting bladder bowel, we should ask about any wetting of undergarments, if any holding maneuvers. Anyone can Google for holding maneuvers and you will see how does it look like. So for all those things, we need to look for.
So Dr. Himesh sir,
Yes.
the corollary question for that. So how do we counsel for the water intake? Age-wise, or there is no role of water intake to be counseled and advised?
Sir?
Hello?
Yes, yes,
Got
sir.
the question? So no. I asked, usually we counsel regarding the water intake. So is there any recommendation for water intake? You have already said it, but as age-wise, how do you go for counseling? So there's no role of water intake counseling in the practice.
Sir, water intake, we need to, in my practice, I do not give a volume, sir, particularly just to maintain a healthy water intake, maybe few glasses in the day. Avoid most of aerated and sugar drinks that we all normally say like that. But I usually do not give a particular volume, because once we talk about that, parents sometimes tend to overdo it. And they try pushing more and more water into it. So we just means there are recommendations of with a wide range for water intake, but in my practice, I do not tell parents for that. And water intake per se, if there is no underlying problem in the urinary tract infection, is not a factor that leads to urinary tract infection.
Yes. The question why I asked, because there are long school hours and most of the children, they do not take water during the school hours. Therefore, probably whether it is linked with UTI, I do not know. So that's why I asked that question.
Sir, in school, the more important is the toilets which are not clean. So that can be sources of infection. For toilets that are not clean, children may hold urine for longer. That leads to your bladder dysfunction. And these are more important predisposing factors in school children for this.
Thank you, Dr. Himesh. Dr. Sadhna, madam.
Yes, sir. Sir, actually, I would like to share, as you have asked. I had witnessed that child. The child was 23 weeker and 600 grammer baby, and the baby stayed around 3 months in our NICU. And but yes, we were not able to wean off respiratory support, and also the growth rate was also very low. But still we waited to grow till 1.2 1.3 kg, and then we went for a device closure, Piccolo device closure at KM Hospital, Pune. The baby was under Dr. Parikh sir and done by Sugawkar sir. And then we noticed a very good improvement. And then after baby catched growth when after around 2 months after discharge. And now this photo, this is around 15 to 18 months. And now the father is also very happy. And my personal opinion is, though in Indian setup, yes, expense is a issue, but we should go but more aggressively towards closure. And I think that too transcatheter device will be much more favorable than surgical closure.
Yes, Dr. Sadhna, we think of this money issue, but I think so most of the hospitals are with charity, and if we pursue that, we get the help from the charities. And thank you, Dr. Sadhna, Dr. Anamika, Dr. Himesh sir, as well as Dr. Pramod sir. Wonderful presentation and expert opinion from your side. Thank you, Dr. Chitra, madam.
Yeah, thank you, sir. And the next month, 1st October, presenter for a topic of anemia, senior resident Dr. Mamta Khandagale has joined. Ma'am, can you say a few words and about our journal journey?
Good evening, everyone. I'm Dr. Mamta Khandale, MBBS DCH, and I'm working as house officer at SPM GMC Yavatmal. And on 1st October, I will be presenting research article, Need to Go Beyond Iron Supplementation for Anemia Mukt Bharat among children under 19. It is an ecological study, and expert for this topic will be Dr. Ajay Keshwani sir, Professor and HOD, Pediatric, GMC Yavatmal. Thank you, ma'am.
Thank you. Thank you. And the second review article about rotavirus will be presented by our past Raigad IIP President Dr. Pramod Wankhede sir. Sir, can I know your comments? Okay. Now I invite Raigad IIP President Dr. Vikas More sir for his comments and vote of thanks.
We can take
Thank you
comments
so
from
much,
Dr.
madam.
Nimen Mohanty sir also, and Dr. Chitra madam. After
Yes,
Dr.
Mohanty sir, your comments about journal journey.
No, thank you, Dr. Chitra. See, my one thing I have to highlight here. This is the shortest possible time we have completed these episodes with the longest topics. Anamika, kudos to you. She has initially prepared 69 slides, brought down to 30, less than 30. That's a good work done under the guidance of our expert. And every word you can see, every sentence you can see, you cannot delete a word, whatever she has done. It's
Thank
very,
you, sir.
very authentic. And why I have kept this topic is UTI is very common. And it has already been brought out that see, functional constipation is 2 to 3% of our children. And in constipation, 20% suffer from UTI, chronic constipations. Because the loaded this rectum sits on the outlet of the bladder. The flow is obstructed. Stasis is there. So frequency of the UTI is very, very common. So when you get a constipation, you find out about the UTI and ask about the symptoms. It's very important. Another thing I want to bring here, although it is not there in the article, the policy in the journal presentation is we do not bring out extraneous facts outside the published paper. That is, if it is done, it will be no end to these things. So we confine our discussion to the paper, and she has done very nicely. In very young children, in less than say, neonatal age or say 2 months age, as she said, jaundice also is a symptom, is a presenting feature. Because of E. coli and this gram-negative bacteria, they cause cholangitis. Also, it is associated cholangitis, and jaundice is usual. Whenever jaundice is there, with fever, you find out whether UTI is there. Is a very indicative. That's a very clinical indication. And for the device closure in PDA, although people say it is a surgical topic, why we have brought it here today, we wanted to emphasize, highlight, reinforce amongst our practitioners that if we come across such cases, immediately refer them to appropriate places. They should get early closure, can be done in 3 days, as you said. In AIMS, I've heard a stint in neonatology for some few months. There, they do it in the NICU itself, device closure. Dr. Rakesh will come and he will bring all these gadgets he will bring to the NICU because they do not have a ICU cardiology, they don't have. So they bring everything to the NICU and do it, the closure there. So it is feasible, doable. So let's do it. And if the child, baby is bigger, let's say more than 7 months old, because the vessel size, they are the fit cases for device closure by catheter. Otherwise, if it's small size, catheters won't pass. So the vessel size also important. Both the presenters have done very well. I'm grateful to them. They were never anxious, very free, and really like good teachers. You will become very good teacher, I can predict now. Thank you.
Yes, sir. Over to Dr. Vikas.
Thank you so much, madam, for giving the opportunity of very important vote of thanks. That is last slide, but I'm so fortunate to have Dr. Shantanu Dev sir as a guest of honor. And especially I'm so much delighted to see the expert Dr. Himesh Berman sir from Meghalaya, the state which I really dream to visit. Dr. Anamika Mall. Really, she has a flawless way of presenter. Like sometimes you also learn from your juniors how you to present a case. So she is one of the case, and the way Dr. Himesh sir has responded to it really remarkable. I was very happy with the conversation between those. So kudos to Meghalaya team. I'm thankful to Neman Mohanty sir. Because of him, we are connected to the Northeast India, like Bengal and Bihar and Jharkhand, and then now we are reaching to the Meghalaya. When I dream to see someone from Arunachal Pradesh also. So really, the way the knowledge is being shared, and we are gradually spreading out. Secondly, the Dr. Pramod Ambedkar sir.
Hello.
Yes, sir.
Yes, sir.
Intervention will save the unnecessary morbidity in the future. I am thankful to our MAHAIP President, Dr. Ram Gopal Chejara sir, Dr. Amol Pawar, Secretary General MAHAIP, and my Dr. Satish Sahane, who is the scientific convener for this journal journey. So these three people are really supportive for their behind our branch to conduct such kind of sessions. And lastly, because though I am heading my team, but I am so much proud of my team from IIP Raigad, our own respectable Dr. Neman Mohanty sir, due to whom this journey is going on, who is ably assisted by Dr. Chitra Kulkarni madam, Dr. Neha Singh, and I have to mention the name Dr. Hemant Gangulia sir, who has started this journey along with Neman Mohanty sir. So that's why we are able to actually enjoy this journey. And lastly, our MMC observer, Dr. Vijay Mandale sir, is with us throughout. And especially lastly, all delegates who patiently heard such a nice science. I joined late, but whatever I heard is really helpful in my routine practice. Thank you so much, everyone, for your participation and interaction. Thank you so much.
And thank you, Mrs. Pallavi Dharmadhikari, for a good support with our technical team along with Dr. Neha Singh. And we meet again 1st of October, 9 p.m. Thank you.
Yeah.
Stop
Thank you.
recording. Yeah.
Thank you.
Nice.
Says